Hello, I'm Dr. Jack Casas. My presentation today is the role of Antigrade Femoral Access in critical limb ischemia and intervention. I would like to extend my sincere thanks to Dr. Walker for having me participate once again in the NCVH talk, this being the digital education series. Additionally, I would also like to give credit for Dr. Jed Miller, who is one of my third-year residents, who helped participate in putting this slide deck and talk together. Disclosures, I have no relevant information to disclose. I have no financial interest in any of the companies or devices that may be discussed. So why take the so-called risk of an antegrade approach? For those of us who have done a lot of these procedures, we have issues with crossing over with the femoral artery access, AAA stent grafts, bilateral common iliac stents, aortofemoral bypass, fem-fem bypass, having a steep iliac bifurcation, and non-compliant, heavily calcified vessels. These are all impediments to a successful crossover. We'll spend a lot of time trying to cross, a lot of fluoroscopy time, a lot of different equipment. Another issue that we deal with are these markedly tortuous vessels. This doesn't look like there's any issue with regard to calcium, but certainly with the tortuosity, we're going to spend an inordinate amount of time trying to get across. Thus, you need to be able to switch over your procedure to an Antigrade Access if you want to be a full service lab. So why do an antegrade and not radial? With the new equipment that's out there, radial approach is very attractive. However, there are several issues with this. There's more fluoroscopy time. You do not have the same kind of support as a direct anterior access. You have sheath size limitations. You are not going to be able to use some of the devices, atherectomy, etc. There's potentially more contrast use, and there's the cost. We have to remember that one approach cannot cover all situations. Your lab needs to be able to keep as many avenues as possible, but remaining fiscally reasonable. The benefits of an antegrade approach in chronic limb ischemia, there is better support. You're going to have less fluoroscopy time because you're only looking at one leg. You're not looking at a runoff. There will be less time because you do have direct access. Thus, your equipment cost is going to be less and your contrast will be less. What are the downsides? There's a long learning curve to this. There's a problem of potentially hitting the profunda or hitting the superficial femoral artery. It's a much higher risk with obese patients. And for those of us who have muscle memory of panning tables, everything is backwards. You move the table where you think it's supposed to go, and it's exactly the opposite of what you think. Complications are slightly increased with antegrade access, and this is related to sheath size. 6 French sheaths are tolerated very well, but you can see by this slide, the incidence of complication rises dramatically when you get to a 7 and 8 French sheath. A little review of the anatomy. Our sweet spot is to hit the common femoral, but you can see how many vessels there are if you happen to stick too low. And that's usually the biggest problem with an antegrade approach. You have to stick much higher onto the lower abdomen in order to get your needle to go into the common femoral. This is a slide showing with obese patients and normal patients how your angles are going to change, but you can look at the obese patient. Where are you starting with your needle on an antegrade access is very much higher than when you're coming retrograde, and you have to keep that in mind. In a true antegrade approach, I would advise, especially early on, using a micropuncture and ultrasound. You want to puncture in the common femoral artery. Again, this is very difficult in obese patients, but it is an indication when you have below the knee disease and you want to have good support and be able to limit the contrast you're going to use. So we've broached this a little bit already. The advantages are better support, and there's a higher success to be able to cross a CTO below the knee. You can reach distal pedal lesions. Again, I stress there's less contrast use. However, for the novice operator, again, the learning curve of getting access is high, and because we tend to use more fluoroscopy time when we're not sure what we're doing, the radiation exposure initially is going to be higher. So what about the retrograde antegrade approach? I'm old enough to remember this series, so what you talk about, Willis? What do you mean retrograde antegrade? Basically, you are going in at a retrograde access, however, you're taking a more steep angle. You're going to get access in the external iliac, and with this particular technique, use a SOS Omni catheter, place your glide wire down the catheter into the superficial femoral artery, pull the catheter back to your access site, then push the catheter up toward the abdomen, and then slide your sheath down, and you will wind up with a common femoral access, but be in the SFA. It takes a little doing at first, but once this becomes commonplace for you, it's a very quick approach, and it is great when you have an obese patient. But the big key is you have to go in a little steeper so that you have the room to be able to rotate the needle from posterior to anterior. Again, this is showing what the technique looks like. Advanced retrograde, place your wire up, SOS Omni, glide wire down the SFA, move the sheath coming from an antegrade approach and slide it down into the SFA. So vascular surgeons came up with a little caveat or a little change on this. And what they did was they took a standard sheath, put a balloon in the iliac artery, took the wire, bounced off the balloon, and brought that back down. That obviated the need for a SOS Omni catheter. Again, whatever technique is successful for you, that's the one to use. But this is the same concept, that you turn the wire around in the external iliac, take it down the SFA, and then reverse your sheath. This is a shot of how the balloon technique was used to be able to get access to the SFA. So in conclusion, while there's a learning curve of approximately 60 cases to be proficient in antegrade access, it is vital for a full service vascular program to be able to offer every opportunity to care for your patients. And what I mean by that is having the standard retrograde access, if you need to come from a brachial radial approach, antegrade access, retrograde access from distal circulation in the popliteal, or pedal access. In the CLI patients, you are going to have more issues because of the inflow anatomy, and antegrade access is probably one of your best ways to overcome the difficulties in crossing a CTO. So I advise, be a wizard at what you do. Surely you can't be serious, and he is serious. Remember, it's all about the anatomy. You want to hit the common femoral. If you happen to get the common femoral and your wire goes down to profunda, that's a very easy fix. Leave the wire in the profunda, take a second wire through your sheath, pull the sheath back into the common femoral, advance the second wire down the SFA, remove the profunda wire, slide the sheath down the SFA. I want to thank you for your time. And just remember, this is a slide of Tornado Watching, which is the #1 rated primetime TV in Oklahoma. Hope you have a pleasant day. And again, thank you for your attention.